we got here. And I'm going to share here. This is another PowerPoint that I put together on the hot topics in HESI. So let me just go over a couple things. And this is what I was talking about, how these exams are set up. They're set up that they want to know if you know how to deliver safe and effective care. They want to know if you know about health promotion and prevention. Remember, nurses, we prevent things. And always remember, choose the least invasive when you're doing these kind of exams too, okay? And then psychosocial integrity and physiological integrity. Okay. So here's my HESI hot topics. These have been on past HESI exams forever and ever. The APGAR scoring. We had a question on impending delivery. Remember, we went over that, how to determine if she's going to be going into labor. Postpartum hemorrhage. They had on the action of the nurse, and they had 6 questions. That's a lot of points, you know. Preeclampsia, how you assess. Respiratory distress, they had 6 questions. Thrombophlebitis and prevention of thrombophlebitis. Ambivalence. We talked about that. They actually had ambivalence on it as the first trimester. Core care. Episiotomy pain. Newborn normal weight loss. Vitamin K injection given to newborn. They had that on there, and they want to know if you know where to give it. And so, and then also it's a trick, it's a kind of a trick question, I feel, that vitamin K, you know, you're going to get a consent form signed. And the parents can say no to the vitamin K. But that's our job, to educate the parents on why we give vitamin K. And then adolescent bonding, diabetes and pregnancy. Oops, yeah, I just skipped here. Let me go back. Diabetes and pregnancy. They do always have a gravid and para question. Alcohol in pregnancy, because we know we see a lot of it. These poor babies come out. And then these cocaine exposed newborn. They always have those kind of questions. Now, some more questions. Molding, how the baby's head molds into the mom's pelvis. Subhematoma. Yeah, caposarcodemia, Pitocin. And I would know Pitocin, I would know the side effects of Pitocin. A positive Coombs test, they always put those on. Delivery in the bathroom. And you say, oh my goodness, right? Delivery in the bathroom. Yeah, they want to know. If your patient is in the bathroom and Sergeant has to deliver her baby, you know, what are you going to do the first thing? And the first thing you're going to ring that call button, right? In the bathroom, that emergency buzzer. Yeah, I've had plenty of patients who deliver it in the bathroom and ring the call button, the emergency buzzer. Ovulation. Tia, they always have a question on ovulation. Postpartum bleeding. Yeah, go back. Postpartum bleeding. Air travel in pregnancy. Spontaneous rupture in fetal heart rate. Breast engorgement. Newborn gagging reflex. That's one of those reflexes that babies have to have in order to survive. Postpartum rubella immunization. Labor progress, newborn heart rate, anemia, like giving her iron supplements. And, you know, how do you give the iron? What you don't give it with? And what does her stool look like? And then backache, 24 weeks gestation. You know, the backache in 24 weeks, that's a pretermer that would lead into preterm labor. So they want to know, they're looking to see, again, prevention here. How are you going to prevent? So these are also some more continued hot topics that I've seen on HESIs. Jaundice, Yeah, RH incompatibility, and what leads to jaundice, breast changes in pregnancy, breastfeeding medication that can be given and breastfed, okay, and then breastfeeding that cannot, such as like HIV patients cannot breastfeed because of the medication. Um, the significance of the non-stress test, reactive versus non-reactive, mastitis, neonatal abstinence syndrome, hypoglycemia, prenatal ankle edema. I would say, and I've said this before, know the vital signs, normal vital signs of the newborn. Okay. Um, Giving a warm blanket post-birth. Well, that's nice for both mom and babies. Breast assessment. And then these are the drugs I've seen: Methogen, Hemabate. They love Carbopress. See this one, Carbopress, and Pitocin and magnesium sulfate. Okay, and your Saunders book has a really good um, chapter on medications and maternity. All right, so that help a little bit? Are you there, Tia?
You can hear me?
Okay, I was asking you questions. That help a little bit? Okay, and
Yes,
Sabria's
I
on. Hi, Miss Simmons. Good. Okay, good.
Hi.
Okay, good. So I am recording. So if you miss anything, you'll see it. But
Okay.
those are the HESI hot topics. Did you see them all? That I have done my analysis on past HESI exams, and these are hot topics that I've seen like over and over again. So let me just go back here. Let me just share that screen back and go back here. Okay. Okay. So in case that you missed them, and I'll give you these slides. Okay. So you don't have to worry. But these are topics that HESI just loves. Okay. And the reason is you might see these also like on NCLEX too, because these are topics that do occur and that HESI wants to know if you're good to go, because again, these are 4 areas on a HESI exam that they're looking at. All right. So let's go on now and we'll get into the meat of things. So I talk about safe and effective care. These questions could be about patient safety. So, like for instance, the nurse prioritizes the delivery of the patient care. So, ask yourself this question, okay, when you're like thinking which one is a priority intervention. Ask yourself, if I can only choose to do one thing before I left this room, what is it? And always remember airway, breathing, circulation. So that goes for any nursing exam, airway, breathing, circulation. And so that's how you kind of break down those choices, because on a nursing exam, it always has like they all good answers. I mean, they really are. This is what they do. They're all good answers, but they're one that is the best of the best. And that's the one that you're going to choose. Now, when you look at seizure precautions for like a high risk patient, think of like say, for instance, how can I prevent a seizure in a preeclamptic patient? How can I keep that preeclamptic patient safe? And so we know that preeclampsia, she can have a seizure even if you got magnesium sulfate, and if it's not high enough for her, she can have a seizure. So what would you think to keep this patient safe? Because you don't want her to hurt herself if she has a seizure. So that would be like padding the side ramps. So that's what they're looking for. And then follow your security plans and procedures, like for your newborns is big. such as your ID bands. So like it comes in a set of 4. So 2 ID band go on the baby, and they have a set of numbers on them. And the other 2, one goes on mom, and then mom chooses another person to put that band on. And again, all those bands have the same number, and they all have to match. Now, say if the baby's band falls off, you have to reband everybody. And you have to do that right in front of mom, and you have a witness to it, so that you know that that baby belongs to that mother. So it's and then of course you have a security actually bracelet on baby, where if the baby goes outside the parameters, it's going to go off. Okay. And that has helped quite a bit. And because there's been baby abductions in the past, and so that was a big topic. The next big area is on health promotion and maintains prevention. So you think of some postpartum complications, postpartum hemorrhage. Hemorrhage is a big topic for HESI. Last quarter, there were 6 questions on postpartum hemorrhage. So you got to think of my patient into hypovolemic shock. You know, you're taking her pulse and she's tachycardic. And then, you know, you see her tachycardia, and then you see low blood pressure. So, you know, these are things can happen. Uterine atony or atony, that's a real soft body uterus. She can hemorrhage. So you want to be on top, massaging the fundus, and if necessary, give Methogen. Okay. And when you give Methogen, you know that you need to check her heart rate before Methogen, because why? Her blood pressure, because Methogen increases the blood pressure. Okay. Then always, guys, Nagel's rule. There's always one Nagel's rule. Okay. So that's how you calculate a patient's estimated date of birth. That all you do is you're going to count back 3 months from the first day of the last menstrual period. Now, write down first day of the last menstrual period, because how students miss this one is that they go from the last day of the last menstrual period, not the first day. So you make sure that you know that, and then you count back 3 months, and all you have to do is add 7 days to that first day of the last menstrual period. All right. And then here you practice your gravida and para. They always have a question on gravida and para. Gravida is the number of times the woman has been pregnant, and para is the number of pregnancies that have reached 20 weeks or greater. And in your HESI book, on page 181, they have a really good gravida and para explanation. Okay. And you know, in case they ask you for the obstetrical history of this patient, they may ask you for the GTPAL. Okay. And so you know that you just plug in. So you can write on your scrap paper, because you're going to have what, 1 piece of scrap paper. So just write GTPAL, and then you can plug it in how many gravida, how many children, how many term babies, how many premature babies, how many ABs or abortions or miscarriages, and how many children are living. Now, remember, twins count as 1 pregnancy, but you give the credit in the number of living children. Okay. Also, do not forget to include the present pregnancy. That's why you're doing an obstetrical history on the patient, is because she's coming to the clinic because she's pregnant. And that's where a lot of students miss out also, is they forget to include the present pregnancy. Okay. So here I put in a patient comes in for her first pregnancy visit, and so she's 6 weeks pregnant. So she had 2 healthy, she had healthy 2-year-old male fraternal twins at 40 weeks. Then she had a miscarriage at 22 weeks. And then she had elective AB at 6 weeks. 5 years earlier. That's a distractor. And so what's her GTPAL? So all you have, and you probably go, oh my goodness. All you do is just write down GTPAL. So how many times she's been pregnant? So we got 1, 2, 3, 4. So 4 times. How many pregnancies to reach term? So you look back up in the question. So I got one pregnancy got to 40 weeks. Okay, good. So I got that. So I got one. How many were preterm? Okay, so I got that. So it's 22 weeks. Okay, because it's past viability. And then how many pregnancies were AB? And she had one, right? And then how many living children? Well, she had twins at 40 weeks gestation. So she's got 2 living children. That's how you just break it down and you can't go wrong. Okay. Pregnancy is broken down into 3 trimesters. Okay. Each one of them are 13 weeks long. So the first trimester is, and they had this on HESI about ambivalence. It's very common for a patient to feel very ambivalent about their pregnancy. You know, sometimes it's unexpected. Okay. Sometimes they, you know, because maybe they have financial concerns, maybe they have career concerns. They're ambivalent about it. That's a normal reaction. Now, that lasts, and then during that first trimester too, it's a hard trimester because you have some nausea, vomiting going on. And that usually starts to dissipate about week 14. So they're feeling pretty, you know, not too good in the very beginning. Okay, a lot to handle. Then as they go into the second trimester, the nausea, vomiting gets better, much better, because the hormones now start to decrease, and that progesterone that maintains the pregnancy, that was the culprit. That was the guy that's the hormone that was giving all that nausea, vomiting. And this is what we call the honeymoon stage, because now they felt the baby move, and so we have some quickening going on, and the pregnancy becomes real, and the pregnant woman now accepts the pregnancy. And then you go into the third trimester, where the pregnant woman becomes more about herself, introverted, and she's, you know, she's worried about herself, she's worried about labor. Oh my gosh, I got to have this baby. Okay. And then she gets, you know, she's got a little more swollen in her ankles, and she's just done. All right. So that's how we look at the different periods in a woman's pregnancy, is by the trimesters. Okay. Now, this is for a woman who's in labor now. Okay, so think about the labor process. Think about contraction pattern and the dilation and effacement of the cervix. So we know that contractions should be a good, effective pattern on the say I'm talking generally, is every 2 to 3 minutes, and the duration is 60 to 90 seconds, and they should palpate between moderate to firm, and they get firm as she gets into the transition phase of the first stage of labor. Okay, so now we got the contraction pattern in our heads, and we got her that she's in true labor because she's changing her cervix. Okay, so if you get a question like that, you know, you know the basics, and so then you know how to handle. So say that she's a woman who, the scenario, which they they put on quite a long scenarios in these questions. The scenario says that she doesn't want any pain medicine, and she is in the she's 5 centimeters. So you know 5 centimeters would be in the active phase of the first stage of labor. Okay, and she doesn't want any pain medicine, so you know how to handle that. You would encourage her to breathe. and you would support her during her time that she's doing all her breathing and maybe doing the he breathing. And as soon as the contraction decreases, you switch her back to the regular breathing. Maybe you put her into the whirlpool, some hydrotherapy, maybe some back, that counter pressure, sacrum counter pressure on the back, because a lot of times there's a lot of back labor. So because you read about the non-pharmacological methods when she's in labor. So you can answer those questions. They also think about the station of the baby's head when she's in labor and how it descends into the pelvis. Okay. So you know that ischial spines is 0 station. Anything above that would be minus, okay, -1, -2, -3, -4. And then you come back to ischial spine, and anything below the ischial spine, like +1, +2, +3, +4, we're getting very close to delivery. Okay, that's a positive sign, which is good. All right. So you have the contraction pattern, you have her in labor, she's changing her cervix, the baby's head is descending into the pelvis. So now you're also monitoring the fetal heart rate, okay, very important during labor. And so we know that fetal heart rate should be between 110 to 160. And we went over veal chop, but if you want to go over again, we can do that right now. So V for variables, and that's caused by what? Cord compression. The E stands for early decelerations, and that's caused by head compression, the baby's head coming down that pelvis. Okay. And then you have the A, that stands for accelerations, which are wonderful because that tells you the baby is neurologically intact. We're good. We're not acidotic. And that is A-okay. And sometimes you have to give maybe a little oxygen as the baby comes down a little bit, especially with earlies, but that's okay. A-okay. And then you got your L, and your L stands for late decelerations. Okay. And when you have late decelerations, that's caused by uterine placenta insufficiency. All right. As you read the scenarios and the questions, you always want to keep in mind veal chop, especially when they're talking about labor patterns and fetal heart rate, and then interventions. So if you need to, you remember lion. L stands for turn the patient to the left lateral position. I is IV solutions, right? Okay, you might have to increase them. O is for oxygen, and we give oxygen 8 to 10 liters via tight face mask. And then N is always you're going to call for help. Hey, I need help here. And then you got to go along with everything, she's having labor pain. And the more she gets dilated, the pain increases. And because too, she feels the baby coming down the pelvis, she feels that pressure. So you want the nurse is the person in the room helping the patient and experiencing the pain. Now we talked about non-pharmacological, but then we have pharmacological, where we can give drugs. So if she needs something to rest in between contractions, you can give like some Nubang or some Stadol. But remember, that crosses the placenta and then makes the baby sleepy. Now, that medication is given in the active phase of the first stage of labor. You don't give a narcotic in the transition phase, okay? Because then when she's in the transition phase, she's dilated, 8 to 10 centimeters, correct? And so she's dilated more and she's getting closer to delivery. So if you're going to give a narcotic, you give it in the active phase of the first stage of labor. Okay. We don't give a narcotic during the latent phase because she's just getting started. And narcotics can slow down her labor. They do slow down the labor, and you don't want to slow the labor down when you're just starting up in the beginning of the labor process. So the timing, so you get this in your head, how to time your medications for a labor patient. And then at the same time, you are also always worried about the fetal heart rate. So HESI does have questions about spontaneous rupture of membranes. And so you always want to note the time of rupture, okay, the color of the amniotic fluid, and fetal heart tones. Okay, so if you're in the hospital, you want to have that lady on the monitor to make sure the fetal heart rate is between 110 to 160. That you have to know. Okay, are you still with me, guys? Just checking on you. Oh, Spria left. Okay, Tia, are you there? All right. Okay, so
Yes, I'm here.
Okay. So the normal fetal heart rate is between 110 to 160. So you want to, keep that in mind. So you got this picture in your head of a woman who is in labor and what the nurse has to be concerned about. Okay. And they also had a question on supine hypotension syndrome, where you have the lady, you put the patient on her back and she gets dizzy and lightheaded. That's a big no-no. You want to turn her up to her side. Okay. And the left side is the most preferable because you have better perfusion of blood. And with blood carries oxygen. All right. So did you get the big picture of a woman in labor, Tia? Okay. Let's move on. So the psychosocial integrity, you have how does a woman adapt to a new role? So they always like to put a bonding issue on there. So how does a nurse promote bonding? Well, she promotes bonding by skin to skin, right? Breastfeeding in the delivery room, very, very important for the psychosocial integrity of both that baby and mom. Also in the delivery, when the baby's born, you want to know the APGAR score. Dr. Virginia APGAR came up with this, and it's just a quick way that healthcare providers, a nurse or a doctor, can assess a newborn and determine if the baby is okay, breathing well, has a heartbeat, moving, crying, and color. So we got the criteria, and if the baby score between 7 to 10, that's a good score. Okay, 10 is perfect. Okay, if the baby scores like between 4 and 6, he may need some moderate resuscitation efforts, may need some stimulation. Okay, that's where you can take and rub them real, with some friction and get him going. Sometimes I would take my finger and just get his little sole of feet and just flick it, and he responded. Okay, he goes, oh, the lady's waking me up. Okay, and then if he's 0 to 3, is really severe. Okay, and he really needs to get full resuscitative efforts, because 0 means there's nothing, and 3 means maybe he's got a very slow heart rate and he's barely breathing, and so he's in bad shape. So you want to be able to get in there. So Tia, they always have an APGAR score on HESI, always. Okay. Now, they do like, and there's 6 questions on respiratory distress. So in my PowerPoints, I do go over respiratory distress and what you're seeing. So you're seeing this baby coming, and he's not doesn't look good. He's got really dusky color, and he's got tachypnea. He is breathing fast. So you know the norm of respirations from 30 to 60. So anything greater than 60, he's tacking along. He's really trying really hard to breathe. And when this baby's little chest retracts inward, it's called retractions. And again, he's trying to breathe. A lot of times there's a lot of mucus fluid down there, and that has to get up. And so we can use a bulb syringe, or we can, suction out a little deeper, especially if the baby's having some really bad problems. If baby's grunting, that's never good on expiration if you're grunting. And so that means they're struggling. And then nasal flaring is never good. That's all these symptoms of respiratory distress. And like I said, HESI had 6 questions on neonatal respiratory distress syndrome. They also put a question on grief and loss. And so it could fall under, how does the nurse talk to the patient who just had a stillborn? Okay, so you want to maintain eye contact and use reassuring touch only if the patient warrants the touch. So first, the nurse would assess her patient and see if she wants the touch, and they usually do. And then you can, talk to her. Basically, you want to create a little memento box. And in the memento box, you can put maybe like a little piece of hair. You ask the patient, would you like me to put a little bit of baby's hair on this little card and put in the box? The name bands that we talked about, we also put that in the box. We take a picture of the baby. As long as mom wants them, we do that. So we create a little memento box. Physiological integrity could be about giving medications. Does the nurse recognize the safe effects of the side effects of the medication? Yeah, you want to know, you want to make sure that you understand about magnesium sulfate, and that's given because they're given to one is given to preeclamptics to prevent a seizure. Okay, to prevent a seizure. Now, if you give too much of magnesium sulfate, the patient can get what we call hyporeflexive. That means they lose their reflexes. That's never good, because by that time now they're losing the ability to breathe, because it can affect the lung tissue too. So you want to be very careful when giving magnesium sulfate, because they can have some side effects. So I'm always checking. Every time I check my patient, I'm checking her reflexes, and easy enough done. And if you find that she doesn't have reflexes, then you have to stop the magnesium, call the physician and tell them, and then he'll order a magnesium sulfate level. And if you've got toxic levels, you always have at bedside calcium gluconate. Calcium and gluconate will reverse the effects of magnesium sulfate. All right. Does the nurse know when a drug is contraindicated? For example, Methogen. I said this earlier, Methogen you give for uterine atony, a uterus without tone, because she probably has Pitocin going. Pitocin's not doing it, so now she needs a little bit stronger. Methogen's very strong. You give it IM, and it can increase the blood pressure of the patient. So you would not give Methogen to a hypertensive patient. Okay, so those would be good things to, if you're not good with your drugs, magnesium sulfate, Methogen, Pitocin, Carbopress, Hemabate, you want to look them up. Okay, now could be a question on monitoring, like the results of the fetal monitor test, such as an NST. We do an NST, a non-stress test. It's a fetal surveillance test. we're looking to see how the baby is doing. Maybe mom got to be 42 weeks gestation. She's post dates. And we know that at this period, the placenta can calcify, therefore, the fetal heart rate can go down. We got to make sure baby's doing okay. Okay, so we can do an NST. If we get 2 accelerations, okay, 15 beats above the baseline, lasting 15 seconds, we've got a reactive test. So I'll repeat that. So a reactive NST is when you have mom, she's marking the little monitor for fetal movement, so she feels the baby move. At the time that she feels the movement, the baby's heart rate goes up. And it goes up 15 beats, and it's lasting 15 seconds in duration. And then it comes back down to baseline. That's a reactive test. Okay. And then also, you always want to review your post-op care, and especially in maternity, what's the nurse concerned about? She's concerned that she's going to look at the funness of the uterus to make sure it's firm. She's going to look at the amount of lochia and see if she's bleeding a lot. Okay. And then with the cesarean, you always check the fundus to make sure the uterus is firm, but also you're going to look at the dressing to make sure that she's not bleeding from the surgical site. Okay. So these are the topics that fall under postpartum complications that you already have studied. And so if you don't know these, excuse me, got dry throat today. And you probably want to look up them. So hemorrhage, hypovolemic shock, a thromboembolic disorder, postpartum infections, subinvolution of the uterus, and mood disorders. So if I ask you a question, what's the first sign of hypovolemic shock? What would you say it would be? Okay, it would be tachycardia. All right, moving right along. These are your signs and symptoms of hypovolemic shock. Tachycardia is your first sign that you see. The blood pressure goes down, causing patient to be hypotensive. She gets pale, cold and clammy skin. And if you haven't recognized that your patient is shocked by this time, then it's going to affect her mental status. And then her kidneys are going to stop producing because the blood is now being shunted to the heart because the patient is losing too much blood. So the kidneys will shut down. Now that you can use in your med-surg classes too. Okay. So we have these are your early signs of a postpartum hemorrhage. So you have uterine atony. We talked about already. Yeah, lacerations, which is a steady trickle of blood. Remember I said about the water faucet just trickling? Okay, that could be higher up in the vagina. So that could have been maybe due to a forceps delivery or a vacuum extractor. She just got cut. A hematoma, and this is really is a collection of blood, and it usually is in the vulva area. Can be very severe, unrelenting pain, and so even opiates don't get it, and they just don't. It doesn't help a lot. If she has a large gush of blood from the vagina, it's an early sign of postpartum hemorrhage. She's saturating that more than one peri-pad in 15 minutes to 1 hour. That's never good because those peri-pads do hold quite a bit. And then, of course, she goes into hypovolemic shock, and you got tachycardia. So what I want you to get out of this slide, again, we talked about all these, is this 4 T's. When you're dealing with hemorrhage or subinvolution, you have Tone, that's how the uterus is. A tone, is it firm? Tissue, do you have any retained placenta fragments? Trauma, okay. Is there any lacerations? Or the thrombin, where she is out, a free bleeder, she has lost her ability to coagulate. Okay. So if I was to ask you, which medication will the nurse anticipate prescribing to control postpartum uterine atony? That would be Methogen. Okay. The terbutaline, that's a tocolytic. Betamethasone is a steroid that we give ahead of time to increase the surfactant in the baby's lungs. And this is what cardiac. So the one that you would want to give to, which is a prostaglandin, it would be Methogen to handle postpartum uterine atony. Okay. Another question. The nurse assesses a postpartum client and she notes uterine atony. What action? Now the question is asking, what action should the nurse perform first? So the action to handle one who has uterine atony would be to massage the fundus. Okay. All right, so now this question asks you, what is the nursing action that's appropriate in the care of a postpartum patient to prevent fundal displacement? Okay, so right, yes, 2. Good, thank you. Yes. So there here you can see the difference in the question, what's asking you. Oh, good. Okay. Here's another one. The nurse is monitoring a client in the immediate postpartum period for signs of hemorrhage. So which sign, if noted, would be an early sign of excessive blood loss?
Will it be the temperature? Oh, no.
It'll be number 2, for tachycardia. The pulse is going up.
Oh, yeah, for sure.
For sure. You got it. Yep.
Yep.
So you see the difference in how the questions are asked. Okay.
Yes, ma'am.
How about another question? So the postpartum nurse is caring for a woman who just delivered a healthy newborn. Okay. So the nurse should be most concerned about the presence of subinvolution, if which occurs. So to answer that question, you'd have to know what subinvolution is. So subinvolution is a delay.
All I can remember is I was gonna say a short when with the sub. I just know that it's a short period of time. Like it's a shorter time.
Subinvolution is a delay in the involution process. So something that's still up in the uterus is causing that uterus to not involute, because we know involution is the contractions that occur, and the uterus will descend back down to its pre-pregnancy state. That's involution, and it usually goes down 1 to 2 centimeters per day. So now this question is asking about subinvolution. So what is still up in that uterus that could be causing this uterus not to descend like it should? What would be
retain placenta fragments from delivery?
Exactly. So see how your knowledge helped you answer that question, right?
Yes, ma'am.
Yeah. So that's how you have to look at those questions. So when it comes to a uterus without tone, remember FFP. Check the fundus. And I know I read on this, I read on your discussion number 4, everybody was talking about how they learned massage the fundus. Well, that's a good thing. Okay, so remember the fundus of the uterus. Remember, you want to keep that bladder empty. So you have a Foley catheter in, okay? And you're going to give a prostaglandin drug called Pitocin, and that makes the uterus contract. So all these things together, FFP, helps you keep this patient from hemorrhaging. All right. So here's another question. On assessment of a postpartum client, the nurse notes that the uterus feels soft and boggy. Oh, here's another one. The nurse should take which initial action? Here you go. You massage that fundus. Okay. All right. I think we got enough massage in the fundus. How about we talk about a DVT? So classic symptoms of a DVT, deep vein thrombosis, include muscle pain, positive Hohenstein, and swelling of the affected limb. Is that true or false? That would be true. So when you have a positive Hohenstein, this is what we're looking at here. This is pain in the leg, in the muscle, especially in the calf. And then she's got swelling of that affected limb. You have to work her up for a deep vein thrombosis because it's very common after delivery that these patients can throw a thrombus. So you have to call the doctor and get a venous Doppler test. Okay, the nurse is monitoring a postpartum client who is bleeding for signs of shock. So which indicates an early sign of shock? I think we already done this one. It would be 2.
B.
B, 2. B, an increased pulse rate of 80 to 100 beats per minute. Okay, you got it. You got it. Okay, let's go and talk about mastitis or these different postpartum infections. All right. Okay, so remember standard precautions. They did have a question on standard precaution on last HESI. Standard precaution helps prevent infections. Hand washing prevents infections. Okay, so you always have to worry about your patient in her temperature. So you have a fever greater than 100.4, that's not good, especially 2 days in a row after the first 24 hours. You have to look for signs and symptoms of infection, and we do. Fever, if she's lethargic, and then you're looking at the different places where she could have an infection. So inside the uterus would be endometritis, and that can occur because don't forget, the uterus was up in there. You know, she had a delivery, you had placenticide, where the placenta actually breaks off from the endometrium, the lining of the uterus, and so that's an open area, okay, inside the uterus. So that can get infected, sure can. And so what we do when we do cesareans, we actually give antibiotic prophylactically, okay? That's because we're cutting inside the uterus. And we know that that's a really good place for an infection can start because it's dark, it's rich in blood, and it's got lots of fluid, so she can get infected. How do you know that she has an infection up in the uterus? Is she has a foul smelling discharge, okay? And then this lady too would have a problem with involution. It would be a slow descent. It wouldn't be the normal 1 to 2 centimeters per day. She would be experiencing subinvolution. So that too gives you a hint that something's not right up inside that uterus. Then she's with this too, with this foul smelling discharge, she is going to have some pelvic discomfort or abdominal discomfort. And so that goes together. And then her temperature will be greater than 100.4. Okay. Now, the urinary tract infection can happen. So we always, when you put in a Foley catheter, you're always going to follow sterile procedure. And we're going to teach our patients after she delivers, do very good pericare, because this is when they can get infections. And it can, go into cystitis, and then it can go into polynephritis when the kidneys get involved. So you want to make sure you teach utmost pericare. Give her the little squirt bottle, and every time she voids or she has a bowel movement, she's going to use that squirt bottle and how to properly go from the front to the back and discard and just pat dry after she uses the peri bottom. Again, you're trying to keep this from happening. Nurses are, we're prevention. We're on the side of prevention. So we also know by increasing fluids will help also with keeping a urinary tract infection. A wound infection. Okay, so she can have a couple areas. If she has a cesarean, she's got a scar on her little tummy. She's got a cut on her tummy, and so that could be an area that can get infected. She can get a laceration or an episiotomy. Remember the different degrees, 1, 2, 3, and 4. And you want to make sure that, you know, you're looking at the episiotomy after delivery. How do we do that? We remember the mnemonic RETA. And so here it is. Here's your evaluation of episiotomy healing. So you're going, every nurse that works the mother-baby unit is going to look at if the patient has an episiotomy for the signs of infection. So redness, we're looking for that. Edema, ecchymosis. The discharge or the drainage would be the lochia, and then approximation of those suture lines. Okay, and you know about approximation, those suture lines should match up really well from one side or the other. And so if you find that there's separation, then there could be an infection going on down there. Again, you want to keep the area of episiotomy very clean. So, and then you also want to give her relief. So for the first 24 hours for episiotomy, you're going to apply ice packs the first 24 hours. And then after the 24 hours, she'll be using the sitz bath and get some relief. And that keeps that episiotomy very, very clean too. Mastitis. Yeah, it's mastitis. Here you have a breast that has mastitis, and you can see how swollen this breast is. And so we want to prevent that. So how do we prevent that? We prevent it by making sure the baby latches on properly. We are going to make sure that we teach mom how to take the baby off the breast. And then we're going to also teach mom not to let baby just suck on the nipple, because this nipple can become cracked and open, and then you get, that's a great area for infection to start. And then if she does, she gets terrible fever. She gets high fevers. The breast becomes hot or warmth. You can see this redness. And then she feels like she has the flu. It's just an awful feeling. And sometimes they have pus, purulent drainage. And so how are you going to treat it? Well, they'll be on antibiotics for sure. And then she'll need something to help with the pain and keep down the temperature. And then frequent pumping, keep the breast as empty as you can. And then warm compresses, support bra, and encourage PO hydration, lots of fluids. She can, if she doesn't have purulent drainage, she can breastfeed. But if she has purulent drainage, you don't. You just pump and dump. Okay. And usually, I'm going to be very honest with you, a woman that comes in has this swollen area. You can see the breast really swollen. Usually the tail of Spence also gets swollen. That's underneath the arms. They usually say forget about breastfeeding. So you want to prevent, again, you want to, a nurse working maternity knows about postpartum infections, and we want to keep it from happening. All right, moving right along. So which information will the nurse include when educating a client on preventing mastitis and promoting the flow of breast milk? How about a warm shower before breastfeeding? Okay, moving right along. Which of the following describes the Babinski reflex? Well, it's about the newborn's toes with hyper. A, yeah, good. And fan apart from the dorsal flexion of the big toe when one side of the foot is stroked upward from the ball of the heel and across the ball of the foot. I put this on there because, yes, HESI likes the Babinski reflex, but know the difference in the reflexes. The rooting reflex, where you stroke the baby's side of his face, and he knows there's food coming, okay? Have the rooting, and we'll go over some more reflex in just a minute. Okay, then how about another question? The nurse is monitoring a postpartum client who's at risk for developing a postpartum endometritis. So which finding, if noted during the first 24 hours after delivery, supports the diagnosis of postpartum endometritis?
Is it one?
It's one. Absolutely.
Okay.
Good. Very good. Abdominal tenderness. Yeah. Okay. How about another question? The nurse is caring for four 1-day postpartum clients. Okay. Which client assessment requires the need for a follow-up? Which one's got to come back in for a follow-up?
3.
No, 3 is colostrum. That's okay. That's normal. Is 4. You've got the logia that's red but has a foul smelling odor.
Right. Okay.
That's so with the questions asking you, you have 4 patients and they're all 1-day postpartum clients, and which one would need a follow-up visit would be that one. Okay, because this one, the first one, the mild after pains, that's normal. Okay, and a pulse rate of 60 beats, that's okay, because patient after delivery, it's usually bradycardic, and so that's okay. And then colostrum is normal, discharge from both breasts, because that's what you want. And then 4 is the one that needs follow-up. So that's how some of those questions can go. Okay, the nurse is developing a plan of care for a client recovering from a cesarean delivery. So which action should the nurse encourage that client to do to prevent thrombophlebitis?
3.
Yes, embolate. Absolutely. Great. Okay, good. Okay, so let's just review a little bit here on these mood disorders. So basically, postpartum blues, or we call them baby blues. Guys, this comes out, it peaks around day 5, and usually by day 10 is good, okay? It does not impair functioning. And this happens when they just don't get enough rest. The baby's up every 2 hours, and she just a lot of emotion. Hormones are just go crazy after delivery, and so that's it. But she loves the baby. She continues to bond with the baby. It goes away usually by day 14. Now, with the postpartum depression, you have a more intense sadness, and you have more of severe mood swings. Now, this one lasts more than 2 weeks, okay? So remember, the baby blues about day 10. This one's more than 2 weeks, so it's going longer. So now she doesn't eat very much. She's not sleeping. And then she has thoughts of maybe self-harm, but that's all. And then it has, she needs help, but she needs support. And if she doesn't, then she may have some feelings of detachment even, and a lack of interest to the newborn. She needs help. She needs to get some maybe antidepressants, some psychotherapy. Okay. Now, if it gets worse, then we call it postpartum psychosis. Now, this one here, she's got some psychotic features. Now, it is a rapid onset, bizarre behavior. She's hearing hallucinations, paranoia, delusions. They hear voices in their head. A lot of bipolar patients can, after they deliver, can get this. And a lot of times they're put into a psychiatric unit, and get the help they need. And the main thing about this is that you have to keep the baby safe. So we have to keep the baby away from mom, because mom may hear voices not only to kill herself, but also to kill the infant. And this is very serious, very serious. So we have to be on alert to these kind of patients, because like I said, it's a rapid onset bizarre behavior. I had patients that had this. And you have to be very careful and keep them in a very quiet environment. And baby does not stay with mom. And mom, eventually my patients went to the psychiatric unit to get help. But at least we recognized it and got her help. Okay, so the nurse assesses a postpartum client who delivered 4 weeks ago. Okay, so there's a clue 4 weeks ago. Now, the mother has little interest in the infant and tells the nurse she's got thoughts of self-harm. Oh, okay, self-harm. And the nurse understands the client's experience in which of the following. So she's just thinking of self-harm, guys. She doesn't have any kind of delusion. No, she doesn't have any kind of adjustment disorder. She doesn't have any bipolar mania. So which one is it, A or D?
D.
D, good. Okay, good. Okay. So I think you can recognize the difference. Just be sure that you read it carefully. Okay, so now we're going to go into the baby's reflexes. So babies that reflexes are an indication of the nervous system. So we want to make sure that the babies can do these reflexes, because the following reflexes, such as blinking, sneezing, gagging, sucking, and grasping, these all keep the baby alive. That's why HESI likes the gagging reflex. It's on every HESI exam. Okay, it's a reflex that actually can keep the baby alive. And so so we want to make sure that they have all these reflexes. Some other reflexes, the moral reflex, gesture startle reflex, rooting. I talked about that. You just touch the cheek in anticipation of food. Baby goes, okay, where's my food? Where's my food? The tonic neck is just a postural reflex. So, sometimes is assumed by sleeping infants. They're so limber, they can do all kinds of stuff. Dancing. Dancing is when, the little feet touch a cold surface and they go, oh, that's cold. So their leg goes up and they look like they're either dancing or walking. And then you got the Babinski reflex. And when stroking the soles of the infant's foot, we do that a lot, and that's a good reflex to see if the nervous system is intact. Okay, all right, we already did that question, so we'll move on to this one. Okay, so your bath. Okay, so baby's first bath is usually a sponge bath. Okay, because you got a cord that you don't want to get wet. You want that cord to dry out. Okay, and when it dries out, it falls off. Then after it falls off, then you can give the baby a tub bath. Now, when you're washing the baby, the head, this portion here, the head, is probably the last to get washed. And the reason why is because heat escapes from the top of the baby's head. That's why after delivery, after we dry them off, we put a little cap on their head, is because they lose a lot of heat through the top of their head. And then we teach mom and dad how to do eye care and ear care, and then how many times they need to get maybe about 2 to 3 times a week with water only, and then teach them from the head to the toe. But I always tell them to leave the top portion to the last. And of course, cord care. Keep the cord dry. So a diapering on a baby who has a cord, you want to put the diaper underneath, okay, the cord. Okay. Now we talk about GI on a baby. This is where they have to have those reflexes. You're sucking, breathing, and swallowing, and the response to feeding cues with the rooting. Those are your reflexes. And then know that vitamin K. Now, vitamin K, the babies are not born with vitamin K. is produced in the gut. So their gut is like we call a virgin gut. It's not there. And so, and it has to kind of accumulate the in the gut, the vitamin K. So that's why we give vitamin K. Helps with keeping the baby from, bleeding out a lot. Okay. So that's why we like to give vitamin K to newborns. Now, HESI does have a question on vitamin K. And so you want to know where to give it. So what muscle would you give vitamin K in? Anybody know? So look it up. The vatus lateralis. Does that kind of give a hint to anybody? And so that's where you give the vitamin K. And HESI likes those questions about that. They want to know if you know where to give it and why you're giving it. And you want to get a consent form to give it from the parents. Now, parents can say no. And that was on HESI. They can, they can question it. Those kind of parents usually are more reluctant to do any kind of immunization. You want to avoid gastroesophageal reflex. You want to avoid spitting up, avoid overfeeding. Baby stomachs are very small and they can only take so much. And so you have to be very careful that you don't overfeed. Now, stool. Meconium is a dark, tarry looking stool, and that occurs within the first 48 hours. And then it will change as the baby takes in breast milk. And usually they'll change by the 4th day. They usually get like yellow and seedy with breastfeeding. It seems like they poop a lot during their neonate time. So if the nurse is caring for a breastfed newborn, what will the nurse expect the stool color to be 5 days after birth?
C.
Huh?
Or
5 days
A?
after birth. Yellow. A.
Yes, A.
Yeah. So again, if you think, oh, there it is, black and tarry, because you talked about meconium. But what's this question asking
A
is
breastfed baby.
yeah, what stool color to be 5 days after birth. See my little question? What's the question asking me? Okay. It's gonna save you, believe me. Okay, so let's go over the integumentary or skin of the babies, okay? And HESI likes a couple of these. So your Vernix caseosa is this baby here. He's got all this really good cold cream. This is, I call nature's cold cream. And this actually protects the infant when he's in utero in the bag of water, okay? And it really works wonderful as a great protective covering. Now, acrocyanosis is where this little guy here, see his extremities, they're kind of bluish. His trunk of his face, the trunk and his face is pink. So, and his legs are pink, except for his feet. Okay, remember, blood getting out to the peripherals like this takes a little longer. And so this should last not more than 24 hours. Okay. And some parents get very, oh my gosh, is my baby cold? Is my baby okay? And it will be okay. But if it goes past 24 hours, then you have to look into the function of the heart. The Milla as the white pinpoint papillars. So let's go right here. See these little white dots, And mommy's saying, oh my gosh, my baby has acne. And that's what I've got. And nervous. And I said, no, those are okay. Because these are like little sweat glands on the nose, and the babies do not sweat for the first 24 hours. So these will go away. And so you just got to reassure nervous moms. Then you have the new eye simplex, which is like a salmon patch. We used to call them stork bites, like the little stork bits your baby. And there's pink spots on the nape of the neck, which is right around here. This is the nape of the neck, and it blanches easily. Okay. And then you have Mongolian spots. And this is a baby with lots of meconium spots. They fade away, but they don't actually go away, but they just fade over time. And you have to be really careful with these babies, because if you bring a baby into after that, you go home and you bring the baby into the emergency room, you have to be, nurses, doctors, we're always on alert as to what we have to think of child abuse too. So be very careful and ask the parents about that. Okay. All right, let me go down
Mhm.
here.
Mhm.
And then you have this erythema toxin, which is a newborn rash. It appears in the first 24 hours. Okay. And then langugo. These are your fine hairs on the body. Remember those? Often disappear during the first weeks of life. Remember something. When a baby is premature, you're going to have more of like langugo. You're going to have more of Vernex caseosa. You're going to have more of maybe, or lasting a little longer, the acrocyanosis. But because the baby's more premature, okay? Babies that are post dates, okay? They've been in there way too long. They use up all their Vernex caseosa. Their skin, they don't have very much when they're born. Sometimes the only place you can see it is in like in the neck, right through here, or in like the armpit, or and or in the groin, but that's about it. Yeah. So you can actually detect, you can actually tell how what's the gestational age these babies are born with how much is left on their bodies. It's kind of interesting. Okay, so right after birth, when the skin of the baby's trunk is pinkish, but the soles of the feet and the palm of the hands are bluish. This is called
See,
B. Yeah, that was
oh,
easy. That was easy. All right. How about another question? Upon entering a client's room, the nurse observes the mother closely looking at her newborn's face and rubbing it. Hmm. The mother states, "How can my baby have pimples?" So, what integumentary condition will the nurse discuss with the mother?
D.
D, right? You said D? D as in dog. Yeah, D. Okay. And this is how they would word it too. Integumentary, which means skin. Okay, good. All right. So let's go on with looking at the head of this baby. Okay. Um, you know about measuring. We're going to talk. Oh, here, this is HESI. One of HESI's hot topics is molding. Okay, so how the head actually conforms to the size and shape of the birth canal. So when these babies are down in the pelvis a long time, like sometimes women, babies have dropped and they haven't gone into labor yet. These babies come out with really big cone heads. It's okay. It will go back down to a normal shape. It just took on the shape of mom's pelvis. We have another condition called capsuccedia. And what you do is you have swelling. Okay, so here you have your suture line. See here? Okay. And you can see that back in the crown right here, you can see even over here, you can see where this would be. It's a collection of fluid. Okay, that's what it is. It's a collection of fluid. And it's okay. It doesn't look pretty, but it'll go down. It could be that maybe it was a tough delivery. You can see how red the area is. This one does cross the suture line. See, here's your sutures, and here's where that capsuccedia would be. All right. Now, when it's on the side of the head, sort of like right here, this poor guy, what a headache, gives me a headache looking at it. That's a cephalohematoma. Okay. Now, because it's on the side of the head, it does not cross the suture line. So on the side of this baby, it would be right on the side here. See, and on the side, it doesn't cross the suture line. See, but that capissuccedaemian, it crosses the suture line. So can you see the difference? Now, what happens with a subfilar hematoma is that because there's a collection of blood under the scalp, that blood has to go somewhere. All right, so the blood's going to be reabsorbed by the body. So what happens, these babies can become quite jaundiced because they have increase of erythrocytes, red blood cells. And so therefore they have increased bilirubin. The liver has a hard time breaking down that bilirubin. And so they become jaundiced. So that's what I put here, hemolysis question mark, is because they have a lot more circulating blood because they have more blood rate in here, collection of blood. Okay. This takes about 2 to 8 weeks to resolve. The capissuccedaemian, because it's just fluid, it goes away in like 3 to 4 days. Okay, yeah. It could be that it's just that they had a tough delivery. You know, maybe it's a big baby, a macrosomic baby coming through a small pelvis. And so remember what pelvis is great for delivering most babies is the gynecord. So this is where it comes into play when these babies are coming down the pelvis and take on the shape of mom's pelvis. Okay, because they got to get their little heads through here. It's tough. Now, the fontanelles, you have an interior fontanelle and a posterior. The interior looks more like a diamond. Here's a picture right here. And here is your posterior fontanelle. It's more like a crescent. All right.
What's wrong? Where?
Barbara, you okay? Okay. So when the fontanelle, either one is they're depressed. So they're not flat on the head, they're depressed. So we have a little indentation. That's from dehydration. Okay. And you have the back here, which is the crescent. You want to make sure that you check that too. Depressed fontanelle is indicative of dehydration. Okay. Now, if it's bulging, then you have increased cranial pressure. So this anterior fontanelle is bulging, it's coming up. So you have increased cranial pressure. Okay, so that's the fontanelles. And a lot of times HESI will put on a question about it. Just read the question very carefully so that you can tell. So how about I issue this question? On a newborn's head, the nurse knows the swelling of the scalp that does not cross the suture line. What is this finding?
Is that hematoma? Is it B?
You got it. Does not cross the suture line. Good. Okay. How about another question? What is the nurse's best response to a mother who is voicing concern about the molding of her 2-day-old infant?
B. It's B. I thought it was D.
Would you say that to the mother? Oh, your traumatic delivery can cause molding.
Right. I thought it was.
Would it be D?
D. Yeah. The baby's head forms the shape of your birth canal. It'll go away. Yeah, that's more reassuring to mom, isn't it? Yeah.
Okay.
Okay. All right. Let's go here. All right. Now I'm going to let you know that HESI likes respiratory distress syndrome. Okay. On my analysis, I saw at least 6 questions on respiratory distress. Okay. So you have, excuse me, I guess somebody just came home. Sorry about that. So what I did for you here is give you a mnemonic called wet prop. Okay. So that when you read the question, oh, goodness. When you read the question, you're going to be looking at the different assessments that they're going to give you. Okay. So I have here for W is wheezing. These are your high-pitched cries, okay? High pitch in the airway. E, the effort this kid is putting out. Is he working really hard? Does he have an inward movement, like retractions? Tachypnea, really fast respirations, like greater than 60 breaths. Remember the norm, 30 to 60. So if you got greater than 60, you got tachypnea going on. Now, for frog, F means flaring. The nasal flare, the nares goes out. That's never a good sign that baby's having problems breathing. Retractions. These are your intercostal or substernal, right below this, right or the sternum. You can see that baby how he's pulling to and really hard to breathe, and that's never good. And then oxygenation, you're looking at color and the mucous membranes, and 92% or greater is okay, is a good percentage for your saturation of oxygen in a newborn. And then grunting, that's never good too. You hear these noises when the baby's go, you know, he takes in, he's retracting, taking in, and when he puts out sounds, he's expiratory. So what I want you to remember is respirations, either they're less than 30 or greater than 60. Kid's in trouble. Okay. If it's bradycardia, his heart rate is less than 110. Remember, normal goes from 110 to 160. So if his heart rate is less than 110, it's not normal. He's got bradycardia. Nasal flaring, he's trying to breathe. He may have like some obstruction. So you want to look. You know, a lot of babies have a lot of fluid. And so that's why we always have the bowl syringe in the crib when we teach mom how to use it. Grunting, never good. And then you have your retractions. And then this baby will have very little tone to him because he's just nothing there. And then he may have central cyanosis. Now that's not good. Remember, acrocyanosis of the hands and feet are normal, but not central cyanosis. That would be
what's the difference?
That would be the trunk. And
Okay.
that would not be normal. Okay. And then tachypnea. Okay. Always, you know, you're looking at sign of inadequate fluid clearance. Again, maybe he's got too much fluid. You're worried about respiratory distress syndrome. You're worried about the heart. Okay. And meconium aspiration syndrome. If the baby had his first bowel movement inside, he passed meconium in utero. When the baby comes out, it's so important that when the head pops out, that we suction. And then we suction as much as we can out of the mouth and nose, and we're using wall suctioning. Now, rest of the baby comes out being born. We do not stimulate this baby to cry. We take this baby over to the radiant warmer, and that's where your NICU nurse and your respiratory therapist is going to be there. And they're going to intubate, and they're going to go down deeper to get more meconium out. The reason is you don't want the baby to take his first breath and suck in the meconium into his lungs. Remember, meconium is the baby's bowel movement. So, and you saw pictures of that. That's really thick, tarry looking stuff. And it could have like some Bernex caseosa in it. It could have like Gugo. It could have all kinds of different stuff in it. And that would go into the baby's lungs. And that could, as you can see here, this would just damage the lung tissue. So we don't want that to happen. So we're going to suction through here to get out as much as we can. And then when you intubate, you do more deep suctioning to get all the meconium back out. Okay. So that's what we want to make sure that we get out. All righty. So what symptom assessed in the newborn shortly after delivery should be reported? See, good. Because he can have a little irregular heart rate shortly after birth, but it will convert. Cyanosis of the hands and feet is acrocyanosis, so that's okay. And mucus draining from the nose. Oh yeah, they have so much mucus at birth. Okay. The nurse is assessing a newborn 12 hours after delivery. Which assessment finding will the nurse report to the provider? Select all that apply.
A,
Mhm,
C,
mhm.
D.
D.
Mhm. Good. Okay. How about E?
Yes.
Yes, good, because it's a low heart rate, it's bradycardic. Okay, good. Okay. Not too bad, but it's low. Okay, because it should be between up to 110 to 160. Good. That's great. Now, the next thing is cold stress. Remember, thermoregulation is a priority after birth, okay, along with respiratory. Those two things. When you cold stress a baby, his temperature will go down. His skin temperature goes down. And then he actually increases, he gets tachypnea because he's trying to keep warm, okay? They don't shove it right after birth. So, this is where he's going to use everything he's got to keep warm. So his heart rate will go down, and then his skin color is not going to look pretty. It's not that modeling looking skin, and it's not pretty at all. And then you have a baby who is lethargic. He's just working too hard. You got him, he's cold. So that's why we assess this baby, and we're going to get a dry, nice warm blankets, wipe all the fluid off him, and get him warmed up. That's why it's so important in the delivery room to have a radiant warmer already on. Because what happens when you cold stress an infant, they're using up all their energy, all their glucose. And so they become hypoglycemic. All right. So now, not only do you have respiratory distress going on with this baby, but now you have a baby on top of it. Has low blood sugar. So that's never good. Okay. So if I was to ask you, which assessment findings will the nurse associate with cold stress in a preterm infant? What would you say?
A.
A. Uh-huh.
B.
He's kind of lethargic. So it wouldn't be excitability. How about the next one? How about decreased skin temperature? He's cold.
Yes.
Yeah.
Yeah.
How about tachypnea? He's trying to keep himself warm. I'm working really hard to keep myself warm. Okay, you got tachypnea. And then tachycardia, you would not have, you would have bradycardia. Okay. Because he's working really hard to keep warm. That's why he's asking you to keep him warm. Okay, so under genitourinary, what I've seen is that you want to make sure that, the baby boy is within the first 24 hours. That could be a good question. Newborns usually have 6 to 8 wet diapers a day, and that's how we usually tell moms that don't worry, that you're doing great with breastfeeding as long as they have 6 to 8 wet diapers. Remember, every mom on the mother baby unit, every infant has a little check-off list, and moms have to check off every time that they change the diaper. Is it a void, or is it bowel movement, or both? And mom has to check them off. What I've seen a lot on HESI is circumcision. Okay. And so I know that on past HESIs, they have the hypospadias on. What it is, hypospadias is where the urethra is not in the center of the penis. It's usually either behind or to the side. So with these babies, even with epispadias too, the urethra is just not in the right spot. So what you're going to do on these babies is that these babies don't get circumcised. Okay. What they're going to do is that they are going to circumcise the baby. They're going to take the foreskin and they're going to make a new opening in the right spot. So that's the kind of question I've seen on HESI with hypospadias. Okay. And it makes sense because with circumcision, you're removing that foreskin. And that good foreskin that they're taking off, if the baby has the opening on the side of the penis, they can make a whole new opening by using that foreskin. And so that's the best way. So as nurses, we make sure that the urethra is in the middle of the penis, okay, to be a normal penis. Okay. Under circumcision, you have to have a consent form. Okay. Nurse is aware that newborns do have pain. And so you want to make sure that maybe you ask the physician, whoever's doing the circumcision, about maybe putting some little lidocaine to help with the pain, because circumcision is painful. You always want to have a bulb syringe by the side, because these babies are going to cry. They have a lot of fluid. They are still going to get up, and then you want to make sure you can suction. A heat source. Yeah, you want to keep this baby warm. This baby is like, you can cold stress this baby, like laying him here. So that's why we put like a little towel underneath him, so he doesn't lay on this cold tray here. And it does look so barbaric, I know, but you got to keep his arms down, his legs down, so that they can do the surgical cut. And you want to make sure you always observe for bleeding and irritation and infection. And the most you can do is, after it's all done, is to let mom just hold him and give him lots of love. Now, that's what I've seen on HESI. With the female genitalia, because of mom's estrogen has affected their little external genitalia, it's sometimes a little swollen, and they could have a slightly bloody vaginal discharge. That's normal, and it will die down or go away. Okay, so that's on that with HESI. Neonatal pain, we know that babies will have a grimace. They have a brow that kind of furrows in. They have little clutch fists, excuse me, and they cry. That's how they vocalize crying. Okay. Non-pharmacological is, just holding them, sidling, let them maybe have a little pacifier if you choose to give that to them. Have them on mom's chest, distraction, and massaging them, keeping them from getting any more intense. Just be aware that they do have pain. All right. I just threw this in there because in order sometimes to answer some of the questions, they're going to give you the week gestation. All right. And so you know this, the preterm is less than 37 weeks. So it's like from 20 weeks, which is viability, to 36 and 6/7 would be a preterm, right? Okay. Then you have your early term. So that means now term is from 37 to 40, but early term would be just 37 weeks to 38 weeks and 6 days. And then you have your full term between 39 weeks and 40 weeks and 6 days. And so these are all term, between 37 and 40 weeks. These are all term babies. It's just how they categorize them now is a little different. Okay. And then your post-term infant is beyond like 42 weeks and beyond. Okay. These are the babies that can have problems too. Babies can have problems being early, being preterm, and they can have problems being post-term. Okay. All right. So here's your complications of preterm births. So we talked about respiratory distress. It definitely can happen with a little preemie. And they have more problems with breathing because they lack surfactant. So what we do is we give mom befamethasone, 12 milligrams, 2 doses, 24 hours apart before we deliver her. Okay. if she becomes, remember I said with pretermers, once they get greater than 2 centimeters and completely effaced, it's really hard to stop these moms from delivering. Even though the drug that we use for preterm labor is magnesium sulfate. Okay. We're giving that to mom. Okay. So she might break through it. Okay. So it looks like it's inevitable we're going to deliver this pretermer. By giving mom that bechamethasone, it helps to increase the production of surfactant while the baby's still in utero. Now, this baby comes out, okay, and he has a pretty tough time breathing. He's going to go to NICU, and what they can do is they can give surfactant as a liquid form. It's called surfactant elixir, and they can put it right down the ET tube because the baby will be intubated, and that will help this baby to breathe better. Okay, so we can do that, and I've seen that on HESI. We give oxygen therapy, and I said before, oxygen saturation 92% or greater is what we strive for. We have a pulse oximeter on this baby because we don't want to over oxygenate it, okay? Because it's not good to over oxygenate a baby because you can cause bronchopulmonary dysplasia, and you don't want to do that. So here's your clinical manifestation of this little guy who's trying to breathe. Again, we talked about it before, tachypnea, greater than 60 breaths per minute. He's having sternal retractions. On inspiration, you hear crackles. On expiration, you hear the grunting noises. He's exhibiting nasal flaring, and his color, he's either cyanotic or he's very pale. You have a pulse oximeter on, and you have your bulb suctioning, and when you do a bulb suctioning, and we teach mom too, is that you want to insert this bulb suctioning into the side of the mouth when you use bulb suctioning. The reason why is and this is on all babies. The reason why is you don't want to put it right in the middle, because if you put it in the middle, you're going to elicitate the gag reflex. You're going to make the baby gag. Okay. So if I ask you a question, which complication will the nurse assess for a preterm infant who is deficient in surfactant?
Respiratory distress.
Yes, you got it. Good deal. So you know the difference between cold stress, hyperbilirubinemia, hypoglycemia, and respiratory distress. Those are the main. And here's some other complications that can happen.
What's cold stress? Is it due to like the temperature, cold stress?
Yeah, cold stress. We talked about that already. Yeah, baby has a low
Sorry,
temperature.
Nurse Irene, I was a little late.
Oh, okay. Yeah, but it's baby's skin temperature is real low. He's wet. He's exposed to the air. He gets cold. From cold stress, you go into hypoglycemia because he's using everything he has to keep himself warm. So he's going down in his sugar level. Oh, and then you can go in from there. You can go into full respiratory distress. You want to avoid that.
Okay.
It's not to happen. Okay. Well, welcome. I'm glad you made it. Associated complications. Oh, you could have a pneumothorax. You don't want that. Here I talked about bronchopulmonary dysplasia. This is by using, guys, is a chronic lung disease, is due to mechanical ventilation or long-term use of oxygen. That's why on these little guys, we put on the pulse oximeter, because we don't want to over-oxygenate. Because not only can we ruin their lungs because of that, we can also ruin their eyes. Retinopathy of prematurity is due to too much oxygen. Can blow out their blood vessels in their retina. So we don't want that either. So remember, 92% or greater is just good amount of oxygen, and that's what we do for these guys. Now, we do for apnea due to prematurity, they can be treated with caffeine. I have seen this on HESI. So if you want to go, you look up this a little bit more, treated with caffeine. Caffeine will increase and wake this baby up a little bit so he breathes. So apnea of prematurity can be treated with caffeine. Okay. Now, some additional complications of a preterm birth. Okay, so all babies, but especially pretermers, because remember, they're born with a low immune system. So pretermers are even lower, right? And so you have the temperature instability in the brain is not mature. He's a poor feeder and respiratory distress. Never good. These are premature. Cold stress leads to hypoglycemia, like I just said. You have excessive heat loss. These babies don't have a lot of brown fat. So they can get very low temperatures. So you don't want to cold stress these babies. And then, like I said, immature heat centers in the brain, and they don't shove up. So what you see signs and symptoms, you have tachypnea, which is rapid respirations. They're lethargic. They're not moving too much. Their heart rate is low, and you have decreased skin temperature. And the color of their skin is that modeling look. It's awful looking. So there you go. Cold stress in a premature baby is even greater than even a term baby. Okay. A term baby has more of what we call the brown fat to help him combat the loss of heat. Okay, then also just like a term baby, these babies can get hypoglycemia. So what you see is a very weak cry. They have tremors. They can have convulsions, and they can be lethargic. Now, a glucose less than 40 milligrams per deciliter is never good in a baby. That's for term babies. Now, for your pretermers, if you get down below 30, you could really run into a baby with tremors and convulsions. So this is not good. Hyperbilirubinemia, absolutely in a premature baby, because their liver is immature and they have so much circulating blood in this little body, and their liver can't handle and break down when they need to break down that bilirubin, and they become very jaundiced. So you would have these babies too under phototherapy lights. And then a really bad situation would be necrotizing enterocolitis, which is you have inflammation of the GI tract, okay? It's very common in a preterm infant. So their little abdomens are swollen and it's real shiny. A pretermer has very thin skin. You can see their veins so easily. It kind of reminds me of an elderly person who, very old. They lose their skin, and you can see more into an older person too. Breastfeeding. Moms can breastfeed these premature babies. If they're on clavage feedings, mom can pump, and we can put the milk in a syringe and feed them clavage. Now look at the diagram, and it could be on HESI. You would have to say where you would stick this baby. When you stick a baby's foot, you're going to do this, see here, the side of the foot. You never go through the middle of the foot. See this here? Never. Because in here, you have nerves and you have arteries. So you don't want to ever do that. You go on the side. Okay. All right, let's move on here. So how about a question? So 1 hour following a normal vaginal delivery, a newborn infant's boy's axillary temperature is 96. his lower lip is shaking. And when the nurse assesses for a Moro reflex, the boy's hand shakes. Which intervention should the nurse implement first? So what's happening here? So you go back and you ask yourself, what's the question asking me? Okay, we had normal vaginal delivery. His temperature is a little low. Okay, yeah, his is low. His lower lip is shaking. Oh, he's probably cold. So he doesn't have his little Moro reflex. His little hands are shaking instead. So what should I do? What should I do for a baby who's cold? Well, for a baby who's cold, you would wrap the infant in warm blankets. Okay? All right, guys. So here are your nursing goals for the preterm newborn. Again, thermoregulation, put this little guy in an incubator. You got kangaroo care. As long as he's doing okay, you could do skin to skin. And in the NICU, they do a lot of this NICU here, and they put a blanket over the baby. Gavage feedings we talked about. HESI sometimes has a question on gavage feedings, and what you have to know is you aspirate before each feeding. Okay, and the reason why is that you don't want to, when you aspirate, you pull back on the syringe, and you don't want to get a whole bunch of stuff, food or formula that you had just given this baby at maybe 3 hours ahead of time. He still hasn't digested it. So you don't want to put more in there. So that's why you aspirate before each feeding. And then, of course, you monitor for meconium. Positioning, you want to always promote drainage of secretions, always. And then change frequently to avoid skin breakdown. Because you can see the baby's skin over here. It is quite thin, all right? And again, he doesn't have the brown fat that a normal term baby would have. So you can see right through. You can see the little veins and stuff right here. You can just draw the lines on there. So if I ask you a question, what is a normal reading of a pulse oximetry of a preterm infant? What would you say? Anybody? 92%. Okay. Which nursing action is most appropriate prior to stating a gavage feeding on a premature infant? You would aspirate aspirate gastric contents because you're doing a gavage feeding. Did you get that one right?
Yes. I was trying
Okay,
to
good.
read the whole sentence out.
Yeah, remember, you got to read the whole thing, right?
Mhm.
What's that question asking me? It's asking me about gavage feeding on a premature infant. I know for gavage feeding, I got to aspirate those gastric contents. Okay. These are just special needs, and we kind of went over this already, but always remember on all babies too, guys. I mean, but special needs of a preemie, you have to improve their respirations, maintain body heat. Babies lose a lot of heat. Remember how they lose the convection, conduction, evaporation. You want to conserve energy because they use a lot of glucose up for energy, and then therefore they can become hypoglycemic. You want to prevent infections, provide proper nutrition and hydration, give good skin care, and observe the infant carefully, of course, and document your observation. And in a NICU, you always want to support or encourage the patients. Okay, so let's move along here. This goes over your post-term infant. Okay, we talked about fetal distress, hypoglycemia. They're overcooked, I say, so they got cracked skin and they're peeling. Meconium stain fluid, like you have to worry about meconium aspiration. Increased risk of birth injuries due to macrosomia, 9 pounds and above coming down a pelvis, coming out of vagina, can cause a lot of birth injuries, such as shoulder dystocia, in which large, wide shoulders causes mom to have a 4-degree episiotomy, plus baby's clavicle has to be broken to deliver. So they are at increased risk of birth injuries. And two, if mom can't push this baby out, they have to use forceps or a vacuum extractor. See, so all this, and then up here, because they're overcooked, they've gone beyond 42 weeks, the placenta starts to calcify and may not give out the nutrients that it needs to, the oxygenation that it needs to give this baby. So babies have a hard time too. Okay. We have seen increases in fetal and neonatal mortality based on going beyond 42 weeks. That's where you do your non-stress test, like we talked about earlier today, to make sure these babies are still okay staying this long in utero. All right, let's jump here to hydrocephalus. All right. The main thing about hydrocephalus is an open neural tube defect, and babies have a very large head, and they have to have their head supported all the time, especially during feedings, because babies, their head is so heavy that they have a hard time keeping it up. Okay, so it has to be supported at all times. What you're looking for is you have increased intracranial pressure, so you have to assess for that. See the difference. And then you protect from infection. We talked about positioning. Always want to promote drainage from the ventricles to the shunt. And then these babies have to have a shunt put in. You put the tip of the shunt here in the ventricle. It goes behind the ear and down. The tube goes down into the peritoneal cavity. Okay. So, and the shunt's got to be pumped. And then they also have to be changed. So you want to make sure that these kids are, kept from getting infections. Okay. All right, let's jump here. So which assessment finding will the nurse expect for an infant diagnosed with hydrocephalus?
2.
2. Yeah, they have a large and rapidly growing head. This protruding tongue with a short neck, thick neck, that's a Down syndrome baby. An inward turning of the ankle and foot, that would be more of your clubfoot baby. And then a hairy patch in the lumbar sacral region, that would be your spina bifida occulta baby. All right. So this is your Down syndrome baby. What I've seen the HESI ask you is what test, antepartum testing, can be done to pick up, Down syndrome. And what your answer would be an amniocentesis. An amniocentesis looks at the chromosomal analysis of fetal cells. Okay, so mothers who are age 35 and above offered amniocentesis in the beginning of pregnancy to right around the time where amniotic fluid is being produced, so that's where you're going in to get it. If she's 35 years and above, she's offered that test. Father is 55 years above, it must have the test, because that's when sperm start to get old and the eggs start to get old on mom at 35. These are the manifestations. The big one is the simian creases and also the protruding tongue. Okay, so those are very much so that you can pick those up very quickly when a baby is born. They have poor resistance to infection, and they're more prone to respiratory and ear infections. And then also they're prone to speech and hearing problems. Yeah, but you can work with these children. They're beautiful children. What antepartum tests can be done to confirm a diagnosis of Down syndrome? And we just went over that. That would be an amniocentesis. Okay. All right. So which of the following assessment findings would lead the nurse to suspect Down syndrome in an infant? It would be a transverse palmar crease. That's called the simian crease, and it's a line straight across the palm of their hands. That's very much so. just go over cleft lip and cleft palate. Cleft lip, you can see here, what you have to be careful about with them is that they don't scratch, if when they get repair, that they don't scratch their incision here, because otherwise they would not have a pretty scar. So you want to prevent the infant from scratching the lip. They have to have a special bottle to assist in feeding. You have to make sure that they do get good, adequate nutrition. And then with the cleft palate here, see the opening. These children are really prone to middle ear infections. Okay. So what condition is commonly associated with an infant with a cleft palate? That would be middle ear infection, which is B. All right, let's move right here. Jaundice. Okay, now heads up. If a baby is born in the first 24 hours, he's got jaundice. That's pathological jaundice. Not good. If babies usually have what we call physiological jaundice, which occurs between maybe 3 to 5 days, or after birth. That's or 2 to 3 days, according to what book you're reading. But that's more of the physiological jaundice. And like I said, it's a hemolytic disease. Basic what happens is that they have their liver is not able to break down the excess amount of bilirubin, and therefore it gets into the bloodstream, and you can see how it changes the baby's color to be yellow. They're very hypertonic. They have seizures, lethargic, can lead to coma and death. Now, if this is not taken care of, this excess amount of bilirubin can cause damage to the brain, and they can get a condition called kernicterus. It's irreversible. Okay, so what we're going to do for this baby is we're going to do phototherapy. Okay, and this slide just tells you about the liver unable to clear the blood of bile pigments. Okay, all right, so here's your phototherapy. What I've seen on HESI is that they ask questions about the baby being under phototherapy. They give you a little scenario. You make sure that the baby's eyes are protected and that he does have like a little diaper on, but most of his body is exposed to the ultraviolet lights because they excrete the bilirubin through feces and urine. All right. And hydrate. Okay, they need to hydrate these babies, and these babies need to be watched very closely. So what we're trying to do is prevent kernicterus by preventing the increased bilirubin levels from the basal nuclei of the brain. Okay, just make sure again that this baby's liver is able to break down this extra bilirubin. So you want to make sure that they get under the phototherapy, and so that they can get it. And we watch the lab results, and we watch the progression, and make sure that they get better. So if I ask you a question, a 1-week-old full-term infant is readmitted to the newborn nursery for hyperbilirubinemia. What supplies should the nurse gather in preparation for the infant's treatment plan? So what would you do? So you're going to get eye shield patches and artificial light source for phototherapy. That's what you do. Okay, so that's what you need. So another question, what treatment will the nurse anticipate prescribe to reduce elevated serum bilirubin levels in the newborn? Well, it would be phototherapy, right? The chilioplasty is a procedure that is used to correct a cleft lip, right? And then we don't need transfusion therapy at this time. And we do laboratory monitoring, but not daily. All right, I'm going to jump now real quick here to hip dysplasia and clubfoot. So just know on hip dysplasia, there is just the head of the femur is not in the acetylbellum like it should be. So there is a little bit discrepancy here. You can see how this foot is down, and this one is up. How the gluteal folds appear unequal. They're unequal. Okay. And the treatment is to keep these hips maintaining constant flexion and abduction for 4 to 8 weeks. To keep the head of the femur within the hip socket. Okay. All right. And the club foot is a very common deformity. It's just where the foot twists inward or outward. And we can put a cast on this baby and help this baby to turn this foot. So here's your normal foot and here's your congenital club foot. What you have to do is you have to provide extra support to the parents. They're going to have to have surgery, and the casts do work very well with these children. All right. So the nurse is assessing an infant, and she knows that the gluteal folds will be higher on one side. So which diagnosis and this assessment finding is consistent with? And we just talked about that. The gluteal fold would be the hip dysplasia. Okay. So how do we prevent spina bifida, hydrocephalus, all these open neural tube defects? Is that the mother takes in folic acid. Okay. And it's always better to take it prior to becoming pregnant. And if she continues to take it until the 12th week of pregnancy, and she's taking prenatal vitamins along with it. With the spina bifida, you have here, you can see how the meninges are on the outside of the body instead of being inside. It's an open neural tube defect. So what happens is that you have to have surgical closure. Okay. So anytime you have an organ that's outside of the body, you have to make sure that it stays healthy, keep it wet. Okay. So you would put like a towel with moisten with saline, sterile saline to keep this. And the positioning of the baby is the utmost, so the baby does not lay on its back. Okay. All right. So the nurse is caring for an infant born with spina bifida, and the degree is myelomeningeal seal. So which intervention will the nurse implement to protect the sac? It would be what? Covered with a sterile cloth, moistened with saline. Well, you wouldn't let open to air and allow to dry. We don't want to do that. We don't cover with petroleum gauze. And so it's covered with a sterile cloth, moistened with saline. Okay. These are some of the metabolic defects in a newborn. So PKU is the big one. Because all babies before they leave the hospital have to be tested for PKU. Because what happens is baby takes in protein. The protein, when it gets into the system, gets broken down into phenolphthalein. Okay, right here, phenolphthalein. And what happens is that because the baby can't break that down, it accumulates in the system. And it can cause brain damage. So we want to make sure that all babies are tested because it can be pretty common. So it's called a Guthrie test. Guthrie test. And so it's a blood test. But you have to do it like 48 hours to 72 hours after birth because you have to have enough protein taken in to able to test it before the baby goes home. Okay. So say mom leaves after 24 hours. Okay. The baby hasn't taken enough protein in to really do a good test. So we tell moms they have to bring the baby back in to have the PKU test. Every baby has to have this stuff. It's not a parent saying, no, I don't want that test. No, this one is a state law in the United States that all babies have this done, okay? It's a lifelong situation. They have to go to dietitians because they cannot take in protein. Okay, all right, and mom cannot breastfeed. So another metabolic defect could be maple syrup urine disease. This is pretty bad because it causes acidosis. Therefore, a baby can die. How you pick it up has a sweet smelling aroma. And so, you can smell the baby and smell the sweet smelling. That's where it comes from maple syrup. So your treatment for this would be hydration, getting lots of fluids in, and maybe dialysis. Okay, it's pretty serious. And these kids can die from a common infection. Okay, these are pretty serious kids. So I've seen this PKU is usually on HESI. If glycosemia has been on HESI, and once in a while I've seen it. Well, how you do it, how you know it is a baby's unable to use lactose or glucose. Okay, so no dairy, no breastfeeding, and has to be on a special formula, soy formula. All right. All right. So I put some slides up here for you that later on you can look at them. Again, PKU, the child has a musty odor. Sometimes they have delayed development, about 4 to 6 months. They have failure to thrive. They have some skin conditions. By the time that you test in the urine and the urine comes up positive, brain damage has already occurred. Okay, these babies appear normal at birth, but it's when they take in the protein and they're not able to break down the protein, break down the phenolphthalein, excuse me, because protein changes into phenolphthalein. They're not able to break down the phenolphthalein, therefore it affects their brain, and it really is serious. That's why every baby has to be tested. Okay. That's just a slide that I put in here again on phenolphthalein in case you wanted to read it. This is where they're on the special low phenolic for their nourishment. It's a lifelong situation. Okay, this is on maple syrup. I'm just gonna go over here. This you can read later. This is on the glycosemia, the treatment and nursing care. Again, breastfeeding has to be stopped, unfortunately. And they go on a soy protein. Because, really milk, like milk has, and lactose, they all contain products. And that can affect the amount of glucose left in the blood. And that's never good. It's not an easy thing. These are not easy for parents to deal with. Now, neonatal abstinence syndrome, that's caused by fetal exposure to drugs in utero. There is a question on HESI I've seen where on neonatal abstinence syndrome. So, because these drugs cross the placenta barrier. And so an infant born to a woman who's addicted will suffer drug withdrawal after birth. They do. They go just like, when adults come off a drug, they go through withdrawals. And for an infant, it really is bad. They also have some long-term developmental and neurological defects. So what are you going to do for these babies? I put a little baby here. You're going to wrap them up real tight, and that's called swaddling, okay? Because that really helps them. And also, you want to decrease the stimulation to these babies. They're not good. They're difficult feeders. Their little stomachs, they can always going, the whole body is just like in a tremor, okay? And so they have a high-pitched cry. They're very irritable. They can have seizures, and they have tremors, and they have yawning and sneezing excessively. Okay. They also, you would see tachypnea. You could have respiratory distress in these kids. Diaphoresis, their skin, just like respiratory distress here. They had that modeling looking skin, and their temperatures, and it's not stable. So these kids can be very sick at birth. And be prone to have respiratory distress. They have to be watched. So again, how does a nurse take care of an infant who's withdrawing from opiates? Here you go. Here's your swallowing baby. And here's how a cute little picture of this poor little guy here. And I've had it where we try to console a baby and try to rock them just like we do a regular term baby, and really give them loving, and they get more agitated. So this is the best way to handle these babies. And sometimes we have to give them phenobarbital. Now, here's our big baby, large gestational age baby, macrosomic baby. These babies are at high risk for birth injuries. Now, hopefully this baby was delivered by cesarean. They're at high risk for respiratory distress syndrome. They increase insulin production in babies, and then they have decreased surfactant for lung development. Okay, so they can go into respiratory distress easily. As soon as these babies are born, their sugar is cut off, and so they get very hypoglycemic. They usually go to the NICU and be watched in the NICU. They also have increased for congenital anomalies that you have to really check inside their mouth with an open palate. They have to check their heart, check their lungs and kidneys. So these babies have to be watched very, very closely. Like I said, they have very low blood sugar after delivery. And you saw this baby here, he's got like a cushionic kind of appearance. That's like we call that moon face appearance. So they're born with that. They kind of look healthy though, because big babies look healthy. Those preemie babies like you saw had nothing to them. This baby has a lot to them, but they also had developmental defects and can suffer complications of respiratory distress. So they also, we talked about hypoglycemia. They have low calcium, and they can have increased bilirubin. So these babies are just like the other babies, can get jaundice. All right. So question. The nurse assesses a newborn who is large for gestational age. Which condition is most likely to be a contributing factor? Anybody?
B.
It's B, right? The mother has gestational diabetes. That would be a contributing factor for a baby large for gestational age. Is that what you said?
Yes, I said B.
Okay. It wouldn't be the mother drinking alcohol in pregnancy. No, those babies don't look that healthy looking. Mother who's Rh negative, no, that wouldn't be a contributing factor for a large gestational age. And preeclampsia wouldn't be either, because we know what those are. Okay. How about another question? A newborn is noted to be hyper irritable with tremors and has difficulty feeding and noticeable yawning. Aha. Which condition will the nurse associate with these findings?
B also.
B. Absolutely. Good for you. Good. How about another question? The nurse knows meconium staining of the amniotic fluid during delivery. So which findings would cause the most concern in this infant? Select all that apply. So retractions would be, right? What's the question asking me? Okay, meconium stained fluid. I mean, we know that's not a good situation, right? So what would cause concern? Select all that apply. Well, retractions are concerned. Tachypnea,
Nasal flaring.
yeah, that's concerned. How about nasal flaring?
Yes.
Yeah. So those would be those are what? Those are symptoms of respiratory distress.
Distress.
Right. And I put down here, remember respiratory distress. Remember, I put that in there because I have noticed on HESI had like 6 questions on respiratory distress. That's a lot of points. Remember, treatment. You want to keep the baby warm. Remember, thermoregulation in a newborn is very important. Giving baby oxygen. Make sure you have pulse oximeter on him. Okay. Cluster care. That means that you do all your care in one setting. Because with babies that are in the NICU, you don't want to overstimulate babies. If a baby's intubated, okay, and on medical ventilations. So this baby is in what? NICU. Okay. I have another question. The nurse is assessing a newborn and she knows a sweet smelling aroma. So the infant's vital signs and blood glucose are all within normal range. Okay. So what condition would the nurse suspect?
A.
Would be C, maple syrup
C.
urine disease. Okay. She knows the newborn has a sweet smelling aroma. That's indicative of that maple syrup. Think of, you ever had maple syrup on your pancakes? It has a sweet smell to it. That's what it smells like. Okay, so I just put here a reminder, maple syrup disease, they have feeding difficulties. They lose their moral reflex. That's the startle reflex. They have hypertonia, irregular respirations, and they can have convulsions. Not good. Okay. How about another question? The nurse is assisting the provider with a circumcision of a newborn. So which nursing actions are the most appropriate? Okay. Well, A. Okay, we want to see what the parents know about circumcision, right? How about getting consent form? Oh, yeah. How about using a heat lamp or radiant warmer and have a bowl syringe? Okay. The one that I wouldn't pick would be instruct the mother to feed infant 30 minutes prior to procedure. The reason why is because this baby, they get really upset on that little board. And what happens, they could aspirate. So you want it just like you have a person go to surgery. You don't feed them before they go to surgery, right? No, they're NPO. Same thing with a baby. Babies don't feed before they have surgery. Okay, HESI will have a question on APGAR. So we make sure that you are well versed on the APGAR scoring. And what you're doing when you're looking for this baby is that Dr. Virginia APGAR, she came up with this system. And what they're doing is you're looking at 5 different areas, okay? And you can tell right away if this baby is going to make it or does he need help, okay? So you're looking at baby's heart rate, respiration, muscle tone, reflexes, and color. So if he has a heart rate, like if he even has one that's maybe below 100, okay, you're going to give him at least 1, okay? If he's above 100, you're going to give him 2. If the baby's crying, you're going to give him, you're going to give him a 2, right? He's crying, that nice vigorous cry. If he's making some kind of effort to breathe, you're going to give him a 1. Same thing with muscle tone and reflexes and color. If the baby's pinking up and his trunk is good, right? But his hands and feet are kind of bluish. You're going to give him what? You're going to give him some credit. You give him a 2. Give him a 1. And then if he's all pink at 1 minute, which not too many babies are at 1 minute, you give him a 2. Usually by 5 minutes, those term babies, healthy babies, will pink up really nice and get a 2. So that's why you're looking at this. So on those questions for APGAR, just read them carefully. All right. And again, if baby You know, you always want to look for respiratory distress. And believe me, HESI has this on the test quite a bit. And in the past, they have a lot of questions. And then you want to always look at the rate and character of the respirations, the color of the baby, cyanotic, and general behavior. Always sternal retractions, grunting, nasal flaring. These are all that get reported immediately to the doctor. Okay. When you're doing, let me see, when you're doing vital signs on a baby, okay, the temperature normally is in the axillary area, okay. Nurses don't really do rectal temperatures anymore because there had been problems with that. So usually nurse practitioner or the pediatrician to make sure that everything is working fine there. But usually nurses, we do the axillary. Pulse and respiration rates, you count them before you take a temperature, okay? Because once you start to disturb these babies, okay, such as taking a temperature, they're gonna cry, okay, because you're waking them up. So you do your respirations and heart rate, which is the apical heart rate. You do that before you take the temperature. All right. Now I put in here, the nurse should report when these things are occurring. So again, temperature elevation, I put in here, pulse rates, respiration, and noisy respirations, and of course, nasal flaring or chest retractions. So that is an important slide. Preventing infections always, because the baby's immune system is immature. So you want to keep the umbilical cords cleaned. And then hand washing again is always, always, always promoted. I talked about this already. The pulse oximetry of preterm infant, that would be 92% or greater. And I went over that already. So this is the reason why is because we don't want to give the baby too much oxygen. You can over oxygenate and cause the bronchopulmonary dysplasia. You can cause retinopathy in this premature baby's eyes, and that's never good. Okay, so we don't want to do that to these babies. We talked about cold stress already. Let's see, I think here we talked about, we already did that question. Let's jump down here. We talked about the fontanelles, the anterior and posterior. We've talked about sunken, which is dehydration, and bulging, which is increased cranial fluid. So we talked about that. So a patient with gestational hypertension is exhibiting all the signs below. What should the nurse report immediately? Which one's the worst one of all? It would be blurred vision. Okay. All right, let's see here. Which is a correct statement concerning the implantation of the zygote? So where does this little zygote, remember in the very beginning, they usually have one question, either implantation, fertilization, or ovulation. So this one's concerning the implantation. It would be the zygote implants in the upper portion of the uterus. Okay. All right, let's go on to another question. What part of the reproductive system is the nurse referring to when talking about the passage between the ovaries and the uterus that the ovum moves through? Okay, so what's the question asking me? Talking about the passageway between the ovaries and the uterus. That passageway is the fallopian tube.
Fallopian tube.
Yeah, okay, somebody is with me. All right. Then the next question, the pregnant client's
Sorry, I'm at work, so I had to keep it on mute.
Oh, that's okay. That's okay. I think I know somebody's with me. The pregnant client's first day of the last menstrual period was June 12th. Okay, this is using Nagel's rule. I can guarantee you this is one on HESI, is Nagel's rule. So remember, we just count back 3 months and then add 7 days. So that would be what? That would be March 19th, right? Yeah. And you have to write the months down. You have to write June, then you have to go back, what, May, right? April, March, right? So you got it. Okay. All right. Here, I can guarantee that there'll be one on the gravidum para. So this question refers to the nurse is obtaining a client's obstetrical history who is pregnant for the first time. So which term will be used to describe the client's gravity and PIC? So she's pregnant
B.
for the first time, yeah. So she doesn't have any living children yet, right? So she's a gravid of 1, para 0. Okay. Gravid 0, para 1, that couldn't be. And this is definitely not. And this is, she hasn't had the baby yet. Okay, so that's easy enough. I did put a reminder in here so you can have it for, looking at later. We talked about supine hypertension syndrome. Remember, put that mom on her left side. Don't ever put a patient on her back, pregnant lady on her back, because she'll get dizzy, irritable, and hypotension. So her blood pressure go down. Okay. And that's what you do. You put her on the left side. Okay, answer all my questions. Okay. All right. Why should the new mom breastfeed her infant? Well, we always said breast is the best, and it delivers.
Antibodies.
Antibodies, yeah.
Oh, yeah, it gives it good antibodies, right? And so it protects. Remember, newborns are only born with 1 month of passive immunity. So this baby, you want to get this baby all the immunities it can get. Okay, all the different antibodies. Okay. All right. Which of the following meals offers the greatest amount of DHA for fetal growth and development?
B. No.
DHA.
Oh, D.
It would be D, correct. Okay, good. All right. We talked about pica. Pica is what? Eating what? Non-food substances, right? Okay, like starch, dirt, anything that's non-food is pica, like chalk. And what you want to know as a nurse, it's okay, you have those, you have those cravings, but as a nurse, you want to know how much chalk are you eating? How much dirt are you eating? You want to really know how much, we don't discriminate and say, well, you should be eating that. No, that's her cravings. And that's called pica. And why is taking folic acid during the preconception period important to reduce the risk for neural tube defects? Yeah, that's what it is. It's important to reduce the risk for neural tube defects. Okay, so best to do it during the preconception period. All right. If not, as soon as she comes in at 7 weeks, we get them started. Okay, the earlier the better, to reduce the risk for neural tube defects such as spina bifida or hydrocephalus. Okay, we just got a few more. The nurse is assisting with cleaning care for a pregnant adolescent. Yes, HESI likes pregnant adolescent. And so you want to look at that. So which of the following is a priority for an intervention on a pregnant adolescent patient? Because these kids don't eat well. B, right, providing nutritional consult with a dietitian. Yeah, these kids don't eat well. Okay, they're they like their fast food, right? Okay, they like their sweets, they like their sodas. So we got to
Couldn't it be C also? Because I've seen a question like that.
It's a priority intervention.
Oh, priority. Okay.
Yeah, for a nurse. Okay, because you're working in a clinic and you're assisting with planning care. See, and we know that healthy moms equal healthy babies.
Right.
So yeah, so it'd be nice to eventually you can, but maybe not during this time. The importance of finishing high school. Okay, that's not a priority for this baby right now. The priority is getting mom to eat better. Okay, see how when you look at that question and you
it can catch me if I don't really read it.
Yeah, and you organize in your head. This is why I say all the time, read the question carefully, And what's the question asking? If you take the time doing that, you'll score 1200 on this HESI. Okay. HESI did have about air travel. So a female client in the first trimester of pregnancy asked the nurse about traveling by plane. So which response by the nurse is most appropriate?
B.
B. Yeah, it's safe up to 36 weeks gestation. Yeah. And again, to avoid a DVT, have her, walk around the airplane a little, inside the airplane, and a little hydration prior to getting into the airplane is always good too. Okay. While collecting data from a couple expecting a baby, the father of the baby states, "I'm very excited that we're going to have a baby. I'm going to show the ultrasound pictures to all my friends." Which developmental phase does the father's statement reflect?
D.
D. Good, good. Just go over in the HESI book about the father's adjustment time and his commitment. Okay, and I think this is my last question, guys. The nurse is caring for a client with a confirmed ectopic pregnancy.
Mhm.
So the client asks what this means. Which statement by the nurse is correct?
D.
Which one?
Is it D as in dog?
Yeah, D is in dog.
Yeah.
Okay, I thought you said B. It's
No.
D.
Yeah.
Now, what is, okay, going back to B, the placenta is implanted in the lower segment. What is that? That's
Fallopian tubes.
placenta previa, right?
Oh,
Yeah.
placenta
Oh,
previa.
okay,
Yeah.
okay.
Remember previa? Yeah. And then you,
Yeah.
okay, yeah. And the cervix was not incompetent. And it's just like the embryo was implanted in the fallopian tube. Yeah, it got stuck in that fallopian tube. So ectopic pregnancy, your patient has a lot of pain in the lower quadrant in her abdomen. And the sooner you get her to the hospital, the sooner the better, so that you can get her maybe save her tube, maybe give her some methotrexate, which will break up those cells, and then the body will reabsorb that tissue, and then her tube is saved. Okay, that's the main thing. Okay, well, that is the end of my little questions. But I hope you enjoyed it. I'll send you, put this under announcements so you can have something to look at if you want to look at it. And I appreciate you coming on board today.
Thank you.
Just keep,
Thank you.
read those questions so carefully.
Okay.
Yeah. And ask yourself, what's the question asking me? How many times today that I have to go back up and say, what is this question asking me? And I look at it, and sure enough, okay, the question's asking me about maybe preeclampsia. Well, maybe it's asking about respiratory distress. Okay. So I don't know if you guys were in the beginning when I started this, but let me just go back here and show you something here. Do review this if you weren't in the beginning here.
Okay.
I put on this one, I put on some really, let's see, hot topics. There's like 3 slides, hot topics. These are topics that I've gotten off my HESI gap analysis.
Okay.
And so these I see like on repetitive tests, okay?
Okay.
Different quarters. Okay, so remember, there's only so much they can ask you, okay? And they're going to have these big scenarios and these questions, and then they're going to ask you a question about it. So then you have to read, you have to know the components of that, okay? And that's why, and that's why we go over all these, because you'll know them all, okay? All right,
Okay.
so just look at that beginning of those slides to see those hot topics, okay?
Yes.
Okay, everybody, with my pleasure. And
Thank you.
I'll be reading your teaching plan this weekend. And then, sorry about discussion number 4. I guess I was just so eager. And if I will recheck your submission on discussion number 4 for your peer responses. Okay.
Okay.
That's it. Y'all have a good weekend, okay?
Yes.
Thank you. You too.
Thank you.
Alright.
You too. Take care. Bye-bye.
You're welcome. Take care, y'all.